Thank you very much. We got a little topic to discuss called Medicaid, and I'd like to get started, and I'd like to hear what our panelists have to say. My name is Dr. Dean Waldman. I'm with the Texas Public Policy Foundation, and let me introduce our panelists. It's an august group. Being a Southern gentleman, I certainly will do the women first, so please understand that's the way it is. Jamie Dudensing is a graduate. Jamie, over to my far right, graduate of both the LBJ, forgive me, School of Public Affairs, as well as Texas Tech School of Nursing. In fact, she began her career as a Capitol nurse. Were you the only one, or were there?
I was a labor and delivery nurse before that.
Oh, good. After babies, adults don't matter, it's only babies. After gaining a master's in public affairs, she served for 2 sessions as the Health and Human Services budget analyst, a difficult job, on the House Appropriations Committee. Later, she joined then Lieutenant Governor Dewhurst as senior advisor for budget and policy, subsequently became his deputy chief of staff and policy director, and currently she is the CEO for the Texas Association of Health Plans, rather large organization. Next is Stephanie Muth, who is the state director for Medicaid. I know you have a bigger title, and I don't remember what it is, but you're the Medicaid boss. Obviously tasked with developing innovative strategies to improve quality and contain costs at the same time, a difficult task, in Texas Medicaid and CHIP. Those who might not know CHIP, Children's Hospital Insurance Program. Children's Health Insurance? Yeah, it's Children's Health, sorry. Those two programs provide medical and other services for more than 4 million Texans. Before this post, Stephanie was the Executive Commissioner of Social Services for Texas Health and Human Services Commission. She has a bachelor's degree from the University of Florida and a master's degree in public affairs from UT Austin. Next is Representative Dr. Greg Bonin. On the end is a Galveston neurosurgeon, small businessman who represents District 24 in the Texas House. He has some relation, I seem to recall, to our new speaker. You're the younger brother? Older brother? You're the older brother, so he has to listen to you.
Oldest of 4. There are 2, and he's the youngest.
Ah, okay. Representative, or shall I call you Dr. Bonin, trained at UTMB, founded the Texas Brain and Spine Center, and later the Houston Physicians Hospital, where he's the chairman of the board. Dr. Bonin is deeply involved in charitable works, including medical outreach and home building. Very interesting. I would like him to make sure he takes care of his hands. Both here in Texas as well as many missions abroad. In the 85th legislative session, Representative Bonin was appointed to the House Appropriations Committee and its subcommittee on Title II, which is Health and Human Services. He also serves on the House Committee on Energy Resources. Now we've got 2 more doctors. Dr. Craig Callawart is an orthopedic surgeon in private practice for, really? You're that old? 27 years?
Yes.
You don't look that old. In Dallas, he serves patients in his office clinic and through the Methodist and Baylor University medical systems. This includes substantial trauma experience at Dallas' busiest, you know, I have to fix my bridge, emergency room. Additionally, Dr. Callawart has served as liaison to the state legislature for 20 years for the Texas Medical Association, as well as the Texas Orthopedic Association. And last but certainly not least, Dr. James Pinkney, as I'm known as Dr. Dean. I don't have a last name, neither does he. His name is Dr. James, is a family physician who founded the Diamond Physicians in 2012. and I'm sure he'll tell us about that. A membership medical practice, also known as DPC or direct primary care. He will explain, I'm sure, this in some detail because it may have great relevance to Medicaid. Dr. James went to Baylor for med school and began training as a general surgeon at Cedars-Sinai in LA, but then switched to family medicine. He is the recipient of numerous awards and even has a patent for an innovative surgical gown, which he developed while he was in medical school. So that is our really quite prestigious, I believe, panel. Let me set the stage briefly, and then we can get to the meat of this. Medicaid. The purpose of us, this panel is to discuss Medicaid. Medicaid was created in 1965 as actually an amendment to the Social Security Act. Same time Medicare became law. It has two sections that I want you to pay special attention to. Most of you know the general concept behind Medicaid, but there are two sections you should note. One is Section 1801, which says, and I quote, prohibition, title is, prohibition against any federal interference in the program, end quote. What that means is it was intended to be a jointly funded, federal and state, but state-run organization. Number two, the other section I want you to remember, if you don't know, I'm going to tell you, which is Section 1115. 1115 is a type of section that exists in every major federal law, which basically says if you got a better idea than our current regulations, you may request a waiver to do it your way for a period of time. And you can get permission from Washington to do it your way as opposed to the way the rules and regs are currently written. Over the last 54 years, as is fairly obvious, Medicaid has become a Washington-mandated, Washington-controlled program, not a Texas-controlled program. By 2011, 1115 waiver, I want to make sure I'm clear. In 2011, we requested an 1115 waiver to essentially put all of Medicaid into managed care. I don't know what the percentage is, but it's over 90%. Jamie, I'm sure, will tell us. And you need to know that. And finally, the current status of Medicaid. Understand that it is the first dollar spent because it's federally mandated out of the Texas budget, and then we have to deal with everything else. In 2013-14 biennium, Medicaid consumed 16% of the Texas budget. In 18-19, that number is now 24%. In other words, a 50% increase in the amount of money that it draws down from the Texas budget, and it's now over $30 billion a year is expended in Medicaid. The last thing I would point out, for those of you who have not either had the testimony or experienced the testimony in the last session about concerns that families have about the level or limit of quality as well as access, I urge you to take a look at that. It's on the video, or you can read the Dallas Morning News expose series of 5 articles in last June, Dallas Morning News, again questioning some real issues regarding the quality of the care. So we have both the fiscal issue and the quality issue. So with that as a preamble, what I'm going to say is the following. Medicaid has some real problems. The question is, what should we do about them? And I'm going to start with, I think I should save you for last, Dr. Bonin, because you're the one who's going to have to do whatever it is the people say. So maybe I could start with you, sir.
Thank you. Thank you, Dean, for inviting me to be here. Craig Callowart, orthopedic surgeon. My involvement with the Medicaid system is largely through trauma. So gunshot wounds, stabbings, car accidents, things like that. I do neck and back work, so it's many people end up paralyzed. And so I interact with the system in order to take care of patients and to have them receive the care they need, which includes respirators, wheelchairs, and a variety of appliances. I finally quit. And I quit not because I just couldn't navigate the system anymore. Forget that it pays me 10 cents on the dollar, but just trying to obtain the medically necessary things that my patients needed became an overwhelming burden on myself and my staff. And then the ever-looming chances of having an audit or an oversight committee look at me to see if I was doing something wrong. And that did happen to my hospital at Baylor University. 19 of my colleagues got nailed by Medicaid. And it got to the point where I just said, I can't do this anymore. So the Medicaid system is there to serve, and it does some things right, but the bureaucracy has gotten terrible, and the fact that we get paid so little makes it not only hard for us practicing physicians, but more importantly, very hard for me to find a colleague that will help me in internal medicine or pulmonary medicine or cardiology. So I've now got a patient who has a problem for which I'm not qualified to treat.
The statistic you should be aware of is less than half of Texas physicians, last number I saw was 47%, can accept new Medicaid patients. So the limit on access is very real. I think before we get to Dr. James, could you speak to this, Dr. Bonin, from the doctor standpoint, not the legislator standpoint?
Certainly. Medicaid is a very frustrating program, as you just heard from a colleague and a fellow surgeon, and he was interacting with it largely in his capacity as an individual who takes care of trauma.
Yes, trauma surgeon.
As a trauma surgeon, and certainly across the medical profession, it's different, the levels of reimbursement, but 10% on the dollar for a surgeon, that's pretty accurate. So good luck finding a surgeon who wants to work at that level of payment on an elective fashion, and those that do really do it as a public service, and obviously it's not sustainable, so it could only be a relatively modest part of your practice and still make your expenses and be able to make ends meet. Certainly it's very bureaucratic in nature, and it's very frustrating, and that's an issue that I was going to speak to. It's one of the challenges that we face. Managed care brings in some good things, and it also brings in some problems that we've experienced on the commercial side, as well as in the Medicaid program. So it's a little bit of both, if you will. But certainly it's accurate that most physicians, given a choice, if they're they're in a more elective field and they're not in OB-GYN or pediatrics, they're going to choose not to accept new Medicaid patients, and that's a real challenge. I will say, with respect to the observations about being I hate to use the word investigated, but basically being investigated, a lot of that is to address concerns of potential fraud. And I think it also harkens back to when we were perhaps more in the fee-for-service model. And so we have concerns even today. But as we've shifted away from fee-for-service, a lot of those concerns are now pivoting toward the contracting practices and best practices in the procurement of those contracts, the transparency of where the dollars are flowing in the system. And because in the past we were so focused on fraud from a fee-for-service perspective, we perhaps don't have currently robust enough mechanisms to see that in the new Medicaid managed care system, we have proper accountability and transparency. So that's just a brief overview. I was also going to speak to it when we get further along the line, maybe from a legislator's perspective.
Yes.
But yeah, we've all experienced everything that you just heard, and that's pretty representative of the experience of physicians around the state.
Before I ask Stephanie to respond to all of this, I do want to point out that when I took a look sort of scientifically at the fraud and abuse issue, one of the things that is not well known, well, we know it, but is not well known by the public, is that a lot of it is actually honest error. And the reason it's error is, A, because the system is so complex and sometimes contradictory that you fill out a form and you think you did it right, and it turns out you didn't do it right, and you're non-compliant. And so error, honest error, and then the rules keep changing. And so I found as a pediatric cardiologist that the rules that allow me to do X changed. And I didn't even know that they had changed. So all I'm saying is that there is a massive amount of complexity which makes it hard in addition to true intentional fraud and abuse.
Yeah, and I would just add that there's probably even more anxiety among physicians anyway with respect to Medicare, but the identical concept.
Yes.
So it's the exact same challenge, but you feel like it's a gotcha game and that you could be badly hurt for an honest error. And that's a different topic. Obviously, we're not covering Medicare today, but
Right.
it's a very similar problem.
Stephanie, you want to speak
Sure.
to this, please?
Sure. I think I just want to start. You spoke a little bit about the cost increases that we've seen in Medicaid, but there's one thing that I do want
If I may, spending increases.
Yes.
Okay.
Our increase in spending, which would be related somewhat to growth. I wanted to highlight, if you look over the last 10 years, the actual primary driver of our increase in the state spending going to support the Medicaid program has been driven by caseload increases. So if you look at per capita spending and you compare Texas to other states, we are actually significantly lower. If you compare the per capita cost growth over the past 10 years in the Medicaid program was 14%. Compared to the U.S. healthcare per capita expenditures, we saw a growth of 30%. So I do think that there are significant steps that Texas Medicaid has taken to contain cost and also at the same time improve quality in the program. But that being said, there's a significant improvements that still need to be made. If you think about the Medicaid program, in order to serve the clients that we have in Medicaid, we have to have a strong provider base that is participating in the program. And one of the primary areas of focus that we have right now is looking at administrative simplification and how to make that provider experience a better experience. We're in the process of transitioning to a new provider enrollment system, and that's going to come with some benefits. Of course, all of these things do take some time, but I feel confident that we have several initiatives underway that will help reduce some of that provider burden and abrasion. And I know Jamie's going to talk. I think part of the complexity is when we move from fee-for-service to a managed care model, you move from one payer and one set of rules to multiple payers and multiple sets of rules, which adds complexity to the program and creates some additional burden for the providers. But I think on the managed care side, they've also been working to see how they can work to streamline that. So I'm sure she'll speak to that as well. There's so much I could talk about, but I also want to just talk a little bit about as the state has made the transition from a fee-for-service model to a managed care model, it really changes the very nature of the role of the state and the job that we do, as Dr. Bonin mentioned. And what we really have seen an evolution in is what is our role in oversight and how can we have a strong contractual oversight over the program. And I believe there's been significant growth in that area in the past 2 to 3 years and some initiatives. One of the things that we received approval from the legislature was we were able to redirect staff from one area of the agency into our managed care oversight. And I think a key area is that clinical oversight piece. So we were able to add additional nurses to our utilization review staff, and those nurses focus on are the prior authorizations being appropriately applied, side, and they're actually going and doing visits to some of the most medically fragile homes to make sure that they're assessed the clients receiving services are assessed properly for those services, and that they are receiving those services that they are assessed for. So I think we've made significant strides, but we need to continue to make that shift from being an organization that delivers services through fee-for-service to a managed care model.
Jamie, would you like to pick up where she left off?
Well, sure, and maybe I'll start. I'd step a couple steps back.
Please.
He said I represent the Texas Association Health Plan, so I represent all 17 of the companies, the Medicaid managed care companies that have a contract with the state. And what Medicaid managed care is, that at one point the state contracted with a private entity that just paid claims. So whatever claim in, they just paid. No one was really paying attention to how many of those claims are going on. Was it good claims? Did it matter if it was emergency room? Did it matter if we have doctors in the program? None of that was happening. So most people just went to the emergency room for care. And about 20 years ago, I think it was in the 90s, someone said, well, what if we turned it into a health insurance model? And said, we're going to pay a premium just the same way your employer may pay a premium for you. Individuals have a health insurance card, and they go, and the contract on this is, instead of just paying claims, we expect you to have a network of doctors. We expect you to have quality of care metrics. We want you to get people out of the emergency room and out of the hospital and have access to primary care. And so we've made this journey for about 20 years. We've been reforming the Medicaid program for over 20 years. And, I think there's some significant things that people haven't recognized that have happened. And I know Chairwoman Nelson, the current Senate Finance Chair, was responsible for so many of these reforms over the last 20 years. And a big one financially, just since 2009, Medicaid managed care compared to what fee-for-service would have cost has saved the state up to $5.4 billion to $13.9 billion. That is a huge sum of money. Before Medicaid managed care, only 1 out of every 10 pregnant women got a timely prenatal care visit. Now it's over 90%. Only 1 out of every 4 kids got an annual doctor's visit. Now it's over 90%. So you've seen these huge changes. We've seen huge changes in individuals not needing nursing home care as much. Nursing home beds in the state of Texas have stayed completely flat for 20 years. Because individuals are being able to stay at home for, it's cheaper. We've also seen, just since 2011, we've seen a 35% reduction in Medicaid for hospital stays for expensive chronic diseases such as asthma and diabetes. So these are huge savings and huge quality of care improvement, which goes to the original, topic of this discussion, which is, can you save money and improve quality of care? You can, right? So that is possible, but that is a hard balance that the state faces. And we talked about reimbursement rates. Managed care companies, these plans, just like commercial health plans, are being asked to provide access and quality that's better than the private market at prices that are lower than 50% of what's being paid in the private market. So you're asking for a huge lift and a load, and it's hard to meet those up. But what we have gotten is more innovation and flexibility. I have a really good example of a plan that I think brings it to a tangible level, and that's in Corpus Christi, Driscoll Medicaid Health Plan there. Dr. Mary Dale Peterson, she's an anesthesiologist that also runs the health plan, realized that all these children were coming in needing oral surgery, these little babies, because, whether it was Coke in the bottle, what it was, but there were all these babies. Medicaid's paying all of this money for the emergency care visits, the oral surgeries, millions and millions and millions of dollars. She tried to teach parents, don't put Coke in the bottle, how you feed the baby, these things, but it's very hard to always overcome these. When she realized if they just all got fluoride varnish on their teeth, which is a very, very simple, cheap procedure, it would be fine, but they don't go to the dentist enough. So she said, well, why does the dentist have to do it? If I can teach all my primary care docs to do it, all the pediatricians to do it. And they're like, oh, we don't do that. We didn't learn that. And no one will pay. The fee-for-service schedule doesn't have a payment claims thing for that. And she said, well, I can do what I want to do because I've been given a premium. I have the flexibility, and I want to do it different. So I'm going to figure out a way to pay you. And every time the child comes in, I want to do fluoride varnish. And there was a 70% reduction in kids needing oral surgery and $8.5 million in savings in just 1 year in this little plan plan in this one town for this one service for just children. It's huge what you can do if you have innovation and flexibility. And I think when we talk about needing more of that, that's the type of thing if we're going to the feds and asking for flexibility, if you let the state do these things, if you figure out what your goals are for the program, you can do some pretty neat and interesting things in the system. And, if I was going to say three things, or a few things at least that I would say with the program, I'm sitting here naming things that we've achieved. And there are other people that say there's issues with Medicaid. But one of the issues I would say in the state of Texas, I don't know what the bar of success is on Medicaid. What is considered the bar of success on Medicaid for reform? What is that piece and what is that goal? And the second piece I would say is there's a lot we can do without a federal waiver.
I'd like to, if I may, and I'm the moderator, but I got to respond with history for that, which is when the 2011 waiver, 1115 waiver, was passed by the Texas legislature, signed into law, and allowed managed care, implemented managed care. The legislature passed another 1115 waiver, which was passed into law as Chapter 537 for the Texas Government Code, but the same Jane Nelson was responsible for the Legislative Oversight Committee to look at that second waiver, which I'll explain in a second, and decided that, bluntly, Washington would laugh at us if we asked for that. The waiver that they wanted was virtually a global waiver so that we could, in Texas, do what we thought was right for Medicaid rather than following a prescriptive set of rules that is handed down from Washington. And Chairwoman Nelson at the time felt that this would be a waste of time, so it didn't go forward. But we have actually in Texas law a code that could allow us to get a waiver that would allow lots of innovation within the Medicaid program, and I'm going to sort of throw that ball to my friend on the end to say, you might want to consider that. Before, or if you want to respond to that, otherwise I want to get to
Well, I was
Dr.
going to say,
James.
we have another panelist I'd really like to hear about. He's got, I think, a unique experience with respect to
All right.
direct primary care.
Why don't you tell us
Yeah,
what you do and so forth?
Perfect. I think talking about innovation and flexibility is a perfect segue into what I do. I'm Dr. James, CEO and founder of Diamond Physicians, and I was a general surgery resident in 2008 at Cedars-Sinai in LA, and I decided to switch over to family medicine to do what I do today, and that is direct primary care. So I actually never practiced in the insurance model. I felt that the fee-for-service model was broken back then. It's still broken now. Private practices spend about 60 cents on every dollar just trying to bill claims and receive revenue, and that's very inefficient. And the national average of face-to-face time with your doctor is 8 minutes. This country spends almost 18% of our GDP on healthcare, $3.2 trillion, and we're spending almost 25% of our budget, $30 billion, on Medicaid, just one program. So there's a lot of work that needs to be done in the direct primary care space. It reinvigorates the patient-physician relationship. So bureaucracy, insurance is completely taken out of primary care. It's the doctor and the patient. We bill a monthly membership fee. It's capitated. The patient pays that membership fee. And they receive unlimited visits, no copays, 24/7 access to their doctor, and unlimited urgent care. Then we go out and negotiate cash pay rates for labs and imaging. So my clients receive x-rays for $60 instead of $500, MRIs for $300 instead of $3,000. And the savings go on and on and on. We also include basic labs, a CBC, which is a blood count, CMP, electrolytes, lipid panel, cholesterol check, A1C for diabetes, and a TSH for thyroid in the membership. We include pap smears for women in the membership. And I can go on and on about what it offers, but basically you're receiving all this value, better care at a better price.
And the key, if I may speak for you, is the direct connection between the doctor and the patient is better for the patient and more satisfying for the doctor.
And that's exactly right. And that's what I'd love to see from an innovative standpoint in our Medicaid program. You know, it's very challenging when you have an underserved population and you have physicians that are opting out of Medicaid, including myself, because the reimbursements are so low. And I love the fact that you guys are moving to managed care, but I think what we need to do to inject price transparency in the marketplace is maybe have a Medicaid HSA card or something where the consumer feels the pressure of the price of the service delivered. I have 8 years of ER experience, and I saw many Medicaid patients in the ER, and the problem is they go to the ER because they don't have to pay anything. And it's fast, and it's quick, and it's easy. So one quick anecdote, I had a 5-year-old boy. His mom took off work because the school nurse said he had pink eye. Took him to my ER. I examined the patient. His eye was just barely red tinge, a little bit of conjunctivitis, if you want to call it that. I don't think so. And I asked him, I said, does your eye hurt? He said, no. 5-year-olds always say, yes, everything hurts. So basically, he had an eyelash in his eye. He didn't have pink eye. I sent them home, and that was probably a $4,000 or $5,000 bill. And I can give you hundreds of examples of that. So if they had to pay a copay, whether it be, you know, $10, $20, something to make them kind of shuttle them to the primary outpatient setting when it's appropriate, I think that would be fantastic.
Jamie, speak.
Well, I was going to say, so that is a good example of something Texas can do today that we don't, I mean, right now, Texas can have the option to add a copay for non-emergency use of the ER. You know, there's some, you know, issues with it we'd have to work through, but it's possible Texas can do that now, but we haven't chosen as a state to do it. So that's a good example of something. The other piece I would bring up, it's not exactly the same as direct primary care, but in Medicaid, with Medicaid managed care, and Stephanie over here, there's very specific contract requirements on my plans to accomplish this. You know, we see the primary care docs as the quarterbacks of healthcare. It's, you know, if they are how you save money and improve quality, if you're investing in something, we pay them substantially more than what the Medicaid fee-for-service schedule is paying them. We also are moving them into capitated arrangements where we can pay them one time a month, and they can choose how many times they see that patient. That patient can come in, how much time. They're able to really coordinate that care. They're doing things outside of just care because they've discovered if I have a caseworker in there that's dealing with their homelessness, their substance abuse benefits, helping them get a job, going through these things that aren't paid for by the state, I save so much more money, you know, doing these social determinants of health. And these primary care doctors in the Medicaid program are setting up these offices, and we're just paying them a premium or a capitated amount per month. And then they don't have prior authorizations. They're not having to go through the claims of paperwork. So that is an innovation that's happening in Medicaid now. It's not exactly the same as direct primary care, but it looks just like it. And we have doctors that primarily do Medicaid work that are going into this and they're being paid substantially more than they were being paid before in Medicaid. And the plans are sharing that saving. So when they do save money in the ER in the hospital, they're turning that also over back to that primary care doctor, rewarding them for what efforts they've accomplished and how they've improved quality and saved care.
Stephanie, you wanted to add?
I just wanted to add
Please.
a couple points. One is that, yes, we added contract requirements. And so by the year 2021, 25% of the payments that our managed care organizations may need to be risk-based pay arrangements with providers. So that number is ratcheting up. It started at 10% in this contractual year, and that does allow for the type of innovation that we're speaking about. But I did want to say one thing about the copays, because there are some federal strings that come with, well, yes, we are able to charge some nominal copays for non-emergent use of emergency room. There's also a federal requirement that on an individual basis that you track that the total of all copays that they pay do not exceed 5% of their total income. So that adds a significant amount of administrative complexity to apply that. Even on a small, limited basis, whereas in the CHIP program, the federal government does allow us to have those copays.
And I haven't told Stephanie this, but one idea that we've had is, instead of the state having to worry about that, we don't mind taking on that admin cost. So the state doesn't have to do it in fee-for-service. They could just allow the Medicaid managed care plans to keep track and do that, because we do think, we have a contract metric that requires us to keep people out of the ER, but it's hard to accomplish, if they just always choose to go to the ER. We try to put clinics, I have plans that put clinics right outside the ER, hoping they'll go to an urgent care clinic instead of the ER. But we do think there are options, because health insurance companies are used to doing co-pays. We know, we track them. We already have systems. We are the computer systems. And so instead of the state having to worry about it, it's something that potentially we could do in the program. The other complexity that I've always heard is, especially for a hospital, so they go to the ER, right? They collect that copay, and and then we reduce their payment, right? And it's hard because they may not always collect it. There may be issues, and then their payment's always being cut from us and the amount of that copay. We like the idea of just viewing the copay as is that disincentive. So we just keep paying the hospital what we were paying them. We don't cut their rate for it. We just really use that copay issue as basically a disincentive for going to the ER inappropriately.
Now, there is a movement around the country, I think, where's Jennifer? I think 16 states have requested waivers that are, the rubric is work requirements in Medicaid, but I think we ought to be clear that it's more than work requirements. It's really the infusion of some elements of personal responsibility rather than only work requirements, personal responsibility, whether it's volunteerism, whether it's education, cost sharings, HSAs, direct care, direct primary care, where the patient / enrollee / client has some skin in the game and has some commitment, if you will, to economize and to not use the ER. If my question is, what do people think about this? And I'm going to say the word work requirements, waiver for work requirements of various sorts that include personal responsibility elements into Medicaid. Anybody want to take that one on?
Let me step back a second. I have enough institutional memory to say that we've been through this in Texas. I was 7 or 8 sessions ago, we required beneficiaries to do a copay.
Beneficiary in Medicaid.
In Medicaid, yes.
Thank you.
And it failed, and I don't remember the exact details why, but I think part of it was difficulty tracking them. Number 2, my experience, which I think mirrored the state, is about 1/3 of these patients are cognitively impaired, either substance abuse, dementia, trauma, whatnot. So it's a very difficult group of patients to take care of. And the third thing is there was a feeling, and I don't know if it was proved, but it delayed care and then cost more. So I think that's why it failed, but that was 7 sessions ago.
It was I helped the member that carried the bill draft it both times, because it's in statute to do the copay. And I will say that the federal government changed the laws around copays and substantially changed our ability and how we can do it close to 2010. When they changed the structure, and then they also recently changed the rules.
Was that part of Obamacare?
Again, I don't think so. I think
Okay.
it was in George Bush administration, maybe a BBA of something.
Okay.
And so it is possible to do. There have been Health Affairs is a premier journal that studied one of the indigent care programs in San Antonio. These are the programs in Texas. We have safety net indigent care programs. A lot of the urban counties provide care for the uninsured, because what we have in Texas is we really don't take care of adults in the Medicaid program unless you're elderly or disabled. We take care of children, pregnant women, and individuals that have disabilities or elderly. We don't really take care of working adults. Most other states, a lot of other states have that. In fact, a lot of the states that you're hearing about work requirements are really, that's where they're applying that, is to adults that can go to work. We really don't cover those populations in the state of Texas, which makes that work requirement situation an issue. But as far as on copays, what we did find in San Antonio was that it was possible to have a nominal copay, and it did have an impact. It did have an effect. But what you do with that kind of copay is, if someone's still needing, if someone comes in an emergency, you still provide the care. And if they can't pay it, you don't sit there and say, oh, we're not going to provide that care, but you just really create that. What we've done in Texas, because we don't have the copay, but the plans have this contract metric to keep people out of the ER, we provide incentives, and the state doesn't pay us for this, so it has to come out of our profits. They're called value-added benefits. And we, and there's a magic number of $25. I don't know why this is a number, that they get, cards for over-the-counter drugs. Or if you're a pregnant mom and you do all your prenatal visits at the end of this, before you have the baby, you get a car seat. So we go through a process of rewarding families if they're doing their well child visits, if they're not going to the ER, if they're making these visits. So we do have a process of incentives in the Medicaid program. The state doesn't pay for those, but the plans do because they've got to hit those contract metrics.
Dr. Bonin, you were ready to chime in?
Sure, and I wanted to take a brief step back and put some of this into context because I think that's pretty important given the practical reality of the session that we're entering into now. And so from a fiscal standpoint, Medicaid is a huge part of the budget of the state of Texas, to the extent that if you, in terms of all funds, I think it's around $63 billion for the current biennium. Medicaid's about, that's HHSC, Medicaid's about 81% of that. But I think more importantly for people to think about, if you if you look back, 18 years, 20 years, you'll see that as a percent of the state general revenue in the budget, the Medicaid program is now taking up about 9 to 10% more than what it did before.
Yes.
And then if you contrast that with public education, that's where it's gone down about 9 to 10% of state revenues as a percent of the budget, and everything else, which is less than 20% of the budget, is essentially flat. So this has been driving the budget, and it's been squeezing out funding for public education. So against that backdrop, another important element to keep in mind is that within the Medicaid program, and of course we have the director to help me out here, I think about 70% of the enrollees are women and children, about 30% are the disabled and the elderly. However, here's the key that you need to think about. It's roughly 36% of the expenditures are for that 70% of the women and children. So you literally have 64% of the cost of the program are the disabled and the elderly. And so this is a great conversation, and there's so much that we can do to improve on the Medicaid program in the state. But from a fiscal standpoint, you can only squeeze so much out of the 36%. And if you're not addressing the other 64, there's a real limit as to what you can accomplish. I wanted to add with respect to direct primary care, in 2015 I authored the bill that established that that's not an insurance product, that it's not going to be governed by TDI.
Yeah, to get around the IRS. Go on.
I'm a firm believer in direct primary care, and then the whole concept around just some personal responsibility, having a fiscal or financial involvement, having skin in the game. We know as physicians that the harsh reality is that it does change people's behavior, and it can be used to change their behavior for the better. The challenge here is if you want to incorporate direct primary care, but if it's covered by the Medicaid program, do you accomplish that same goal? And do you still have the buy-in or the engagement of the enrollee when it's just another paradigm for how the state and the federal government are paying for their care? And I'm not saying the answer is that it's not possible. I'm just saying it's a different environment. And then what you just heard is 100% correct, which is it's a different population. And there's a percent of that population that, frankly, struggles. They struggle with not only their physical health, they struggle with mental illness, and expecting them to be able to be disciplined and responsible and to manage their affairs is not always reasonable. And so how do you effectively manage that subgroup of the Medicaid population? So that, and then there are some other points I'd like to make, but I want to hear what the other fellows have to say
Yeah, let me
about that.
just jump in real quick. Those are great points. I think the key differentiator between DPC and the managed care model is time. So we have 8 physicians across 4 locations in the DFW Metroplex, and our docs spend 30 to 45 minutes with each patient. So if someone, I have special needs clients, I have kids with Down syndrome, it's that time that allows us to really dive into lifestyle change, behavioral change, turn back chronic disease in the disabled. And I really think that that is what is the key, that why DPC can be so effective, is that the doctors have more time. And also from incentivizing doctors to take care of this population, we have to pay them a little bit more, and we don't have the funds. We can change the way that budget is allocated with DPC because we reduce hospitalization and chronic disease by 70%. So those are key factors that...
Dr. James, I just want to make sure I'm clear and they're clear. When you say you have more time, am I correct in saying, and I don't want to put words in your mouth, am I correct in saying that that's time that you would have spent with bureaucratic billing, et cetera, that you now can spend with the patient?
That's right. I don't do any CPT codes. We just spend time with the patients.
Well, but let me...
That's
So-
quite a luxury.
So let me tell you that I agree 100% with that, and actually I have some experience with wellness and also with more of a concierge model in addition to DPC. But I heard an important leader in the nonprofit sector actually once say that what he envisioned was using technology so that physicians could more accurately assess and prescribe how to better manage the medical management of people with hypertension and diabetes, trying to prevent coronary artery disease, and that they could do all of this within 5 to 10 minutes.
Yeah, we
That's
do that too.
Well,
80% of our
here's-
visits are telemedicine
So
visits.
respectfully, I'm with you that it's much better to have that FaceTime with the patient. In other words, 21st century medicine is disease prevention. It's not how can I see someone in 5 minutes and prescribe the right pharmaceutical. I mean, that's an element of it. And you asked, is that time you would have spent on administrative tasks, perhaps a component of it? But to correct me if I'm wrong, part of it is that you're paid so little for your E&M codes by the commercial carriers or by Medicaid that you can't make ends meet if you aren't seeing a higher volume of patients. And so that's the other aspect. It's not just the administrative costs, it's that
Sure.
the pay is so low that you cannot function if you spend more than 10 minutes in the room. And what this does is it liberates you to spend 30 minutes with that person and to really get at the root cause of what is going on with their health, and to help to educate them and to modify their behavior.
I was talking to Dr. Calloward before we started and making essentially that point, which was if I'm a pediatric cardiologist, we are supposed to see an established patient every 15 minutes, benchmark, okay? Well, excuse me, it takes me 15 minutes on the floor playing with a child before I can actually examine him. It takes me 11 minutes to get through the e-prescribing program. Any doctors in the room, they know exactly what I'm saying. My point is, all this other stuff that isn't the practice of medicine gets in the way, and I'm looking at him envious, saying, I'd like to be able to just sit on the floor and play with my patient so that I can then examine him and figure out what's going on.
So I want to give you an example. There's a clinic in Fort Worth called CareMore Clinic, and it gets paid like a direct primary care. They don't have to do the claims. They don't have the prior authorizations. They see patients. I was there. They see a patient for an hour if they need to. They also have social workers there, psychiatrists, a pharmacist there, an entire team to do everything to manage the fact that we were talking about that 35% of population that is most of the cost of the program, because they're helping them get housing. They're helping deal with their behavioral health, substance abuse issues. They're helping make sure that, because they're on so many different drugs, they have a pharmacist there. They have a room where they go and all meet on that patient, and they have the time to do that. And the primary care docs and nurse practitioners, they're seeing it, and the entire clinic is housed around providing all of those services, however long it takes, and they're just paid a premium per month.
Does
for
the
every
patient
they
have
see.
any personal responsibility in
Well,
this?
no, in the Medicaid program, no matter what you do without other federal, like I said, you can have an emergency copay, but no, they don't. Instead, what they're doing is they're helping. I mean, it's the incentive model of providing these things, but it's working.
My point is, when you look at, and I like the analogy of of what the Personal Responsibility and Work Opportunity Act of Congress in 1996 did to TANF and SNAP food stamps and so forth, it had a profound impact on the population. And go ahead.
Yeah,
You can
and
have the
we-
you can have the last word, and
Yeah,
then
we're
we
getting
can.
the message to move on to question and answer.
Please.
But back very briefly to session, I think you're going to see an effort born out of a frustration and a recognition that one of the areas where perhaps we're failing the most is with the sickest in children and the people that are in the greatest need. And so there will, I think, be an effort to look at the fair hearing process, to look at pre-authorizations, and
Delaying necessary care. Go on.
Correct, and to address those, because we don't, we can't have a program that fails to meet the needs of the very people that we're trying to serve. And so Medicaid managed care has done some helpful things. It's just like anything else, and it can be out of balance, especially with a certain patient population, and there has to be proper oversight and accountability for that, and that will be definitely on the agenda for this session.
Thank you, because I wanted to end by asking you where we're going with the session, and you just answered it. Now I'd love to open up the discussion. Where's our mic? There she is. Why don't we start with the gentleman in the back?
Thank you very much. I think this is an amazing topic, and I want to specifically ask between the Medicaid and also Dr. Pinckney. So I served as general counsel for 2 years for a medical cost-sharing company located here in Austin. A couple of things I think might be interesting for Medicaid to do is give the incentives to people to save money to go to that direct primary care model, because what you're seeing is the ERs, they just go there and they just want to use an endless service. I mean, if someone advertised me a select meal versus a buffet, I'll probably choose the buffet every time because it's unlimited, right? If Medicaid was just making one membership payment to a direct primary care, it seemed like it'd save a ton of money because you're not wasting all the time on different billing codes for every single procedure to see what's covered or not. Second, telemedicine. My wife and I have used Teladoc over the last several years. We have 5 kids, and it's been amazing. I think a lot of people who are staying at home taking care of the child would much rather use Teladoc at home rather than to dress up the child who's sick or may not be sick into the car, drive to the ER and use it. And if you could offer those services, then it might be just a smaller payment
To the Medicaid population.
to the Medicaid population, rather than an extensive network of paperwork and codes and more bureaucracy that's going to waste a lot more dollars.
Stephanie, you want to say whether you think that?
So telemedicine is definitely, that is something that we utilize in the Medicaid program and are looking at ways to continue to maximize. Another perfect example is, I mean, there may be, not all physicians are enrolled in the Medicaid program, but in some cases, we just don't have specialists in various areas of the state. We have a lot of rural areas, and telemedicine is the perfect solution in those examples. And we do have a funding request. There was a bill that passed last session for rural hospitals it's that upfront cost of some of the telemedicine equipment. So while we will pay for the visit, it's the infrastructure that's involved in some of the telemedicine that can be a barrier to full utilization. So, but that's definitely an area we do see telemedicine as a solution.
But one thing is a really good idea that we don't do is urgent care, like you were saying with Teladoc. So you have telemedicine that's like a visit. You have your doctor, and he calls you on the phone, and you have sort of your phone call visit. But we don't really have urgent care telemedicine, like what you would talk about with Teladoc or that type of thing, where it's just sort of, oh, I'm not, I think I have this. I was going to go to the emergency room. Can you help me get what I need with that? We don't really use that as much of Medicaid yet. That was really created last session, and it's now showing up more in the commercial market. But I do think that's an area where we could have more improvement in the Medicaid program.
Yeah, so telemedicine is a fantastic way to engage with patients. But the problem with telemedicine is there's no continuity of care. So you can't watch the disease progression, and a lot of times telemedicine doctors will just send them to the ER if someone has chest pain or something like that. Whereas in DPC, we have a telemedicine app called Dr. Link. You still get that same provider every time you call in, so that would be a great aspect for Medicaid to maybe dive into DPC
That
model.
is a
telemedicine.
very important point. Please
and then
continue.
Your first question about Medicaid paying the doctors directly, we've actually done that in DPC. Q Lyons out of Washington State had a Medicaid contract, and it was unfortunately unsuccessful. So most physicians in my space, we don't want to be paid by managed care. We want to be paid by the patient. So I think an HSA card would be the best solution for that. If Medicaid could fund an HSA card for the Medicaid population, and then they pay us directly, that would be something that we could actually, I could push that through the DPC ranks.
Where's my mic? How about this young lady here? You're young.
Wonderful, thank you. I would like to know if you've seen any new incentives, disincentives for the care from long-term care Medicaid into the emergency care setting.
We, in our contract, or a number, one of the areas that you really have around long-term care back in is readmissions back into the hospital or for certain admissions. So we have something called potentially preventable admissions and potentially preventable readmissions that are measured. So say someone was in a nursing home or in a long-term care setting and they're not getting the care that they need and they get an ulcer on their skin. And they end up having to go into the ER and into the hospital for something that was, if they were getting quality of care, we all now get dinged for that. So, and the HHSC, and I can let Stephanie talk about, is consistently creating these incentives through every kind of provider and on the managed care companies, so that we all, because that's one of these weird things in all of healthcare, private, Medicaid, everybody has a different incentive, right? The money has always been messed up with the way the incentives work in healthcare, because the sicker someone is and the more care they need, the more you get paid, versus, did I keep someone healthy? Did I do a good job keeping them in the ER? I just lost revenue. I just lost a lot of money. So there's this entire world of trying to switch this process. So HHSC is creating these metrics. They measure them. You can look at them. There's a portal online. Speaking of transparency, there's a portal online that has all of this. You can look at it by hospital, by area, by Medicaid managed care plan, by product line, by age, by gender, any of these measures by measure in the state of Texas. You can also see it kind of with the general population and with Medicaid. So they're measuring this, and then what they do is they say, well, we're going to take 3% of your dollars away from you if you don't hit these metrics, and if you're not constantly improving. And they do the same thing to the nursing homes, to the hospitals. Go ahead.
How about this gentleman? Anxious, so let's let him speak. Please.
Anxious because I got a text from my wife, so I'm also wise.
Is she pregnant?
So, a quick backstory. My son's had 4 open heart surgeries, suffered a stroke, had a brain tumor, and I work for a nonprofit. My wife has 2 jobs that she works from at home and is going to school right now to become a PA. For pediatric cardiologists and cardiothoracic surgeons, we think you're a gift from God. We appreciate you so much in our lives. On that, though, I've had the pleasure of living in Texas as well as living in California. Maybe not as much a pleasure, but the state did give a lot. And while we make a decent income, we don't make enough to cover the costs of our son. Where you have a great PPO, but my wife's question is advocate and find out how to get children with disabilities, Medicaid or secondary Medicaid, to be looked at as an individual and not based off of family income. And as you're going into this next session, is there a way that that could happen or that we can help you as a family? Because there are other families like mine who are struggling to just make ends meet because our son is looked at as a family and not as an individual.
So some of the waiver programs do allow children.
We were part of DADS at one point, and no longer a part of DADS because there's a wait list as a result.
Yes, so what there is
Explain what DADS is, please.
So it's gone away now, but it was the agency that dealt with all of the aging and disability programs, and the interestless programs, which are also waivers, not the 1115 waiver. I forget
Yes.
their other number waivers in the program provide and have been added in over the years. Have found ways, because what we found is we do treat these kids if they're in a hospital or a nursing home, and we used to have children in Texas in nursing homes. It was, I mean, when I first started, one of our biggest efforts was to get kids out of nursing homes, which is really sad, right? And by the way, it's also more expensive for someone to be living in a hospital and living in a nursing home instead of being at home with their family. So the idea was we're going to get them back in the community, but it's not an entitlement in Medicaid the same way a hospital or a nursing home is. So they created these waivers, and there's waiting lists or interest lists for these programs. It takes the legislature appropriating money to reduce those lists. So the best way you can advocate for those programs is to come and advocate that they appropriate money each session to reduce that list on the program.
And I will just add that we do have an exceptional item request in for legislative consideration during the session to reduce those interest lists for various programs.
And one of the things I want to add to what we're saying here is one of the things we do not well, I'd say not much at all, is in our calculations discuss avoided cost. I'm looking at my friend in the end here saying, hey, I got a little problem here. I don't have any more money. Well, we have to take a longer view than next year's budget and say, well, if we spend $5 million here, 4 years from now, we're going to save $80 million in that, whatever that is. And I think we need to always include those calculations of avoided costs. And your family is, your child is a good example of how we might be able to, oh, by the way, the child will be better, but okay. But if we're only talking money, if we can spend some now and not have them institutionalized, for example, and all the problems that occur with institutionalization, the medical risks, financial risks. So you want to comment on that?
So I agree, with that assessment, and there are multiple populations in which we need to consider that. I think one that you'll probably see come up this session will be the duration of the postpartum period during which a woman still has
Yes.
Medicaid benefits. It's currently, I believe, 60 days. And there's a real recognition that extending that would do exactly what you just described. It could save a lot of money, but more importantly, it could save a lot of women.
Lives.
And so I think you're going to see that type of logic and thought process applied as we make these policy decisions in the next few months.
Where's my mic? How about this young lady here?
Okay. My background is Executive Director for Orthopedic Spine and Neurosurgery. I ran some activity-based costing analysis on the cost to produce services. I could never get above or below the Medicaid level of reimbursement. That we would never be reimbursed from Medicaid for what it cost us to produce the service. Number two, I ran a medical malpractice analysis on my clinic, went back 20 years, and 5% of our patient population were Medicaid. Guess how many of our medical malpractice lawsuits those 5% drove? Guys, take a guess.
I don't want to guess.
Don't want to
Thank you.
guess? 80%. That 5% drove 80% of our malpractice suits. Okay.
And that's a very important point.
Yes.
It's a litigious group.
Go
Not
on.
only do you not get paid, but you have all the trouble that goes with it.
But I would submit the following. Yes, everything we all say is true, but I have to question whether changing an entitlement mentality to a mentality that has some personal responsibility in it will change the paradigm. And I'm not saying it's easy, and I'm not saying I know how to do it completely, but I will comment that Jamie made a point before about how many people are cognitively impaired and very expensive, et cetera, and you brought that up as well. We did an analysis in a paper that will be coming out shortly on work requirements in Medicaid. If you look at the population in 2017, 265,000 Texans out of 4.1 million, I will grant you, was 4.1 million in Medicaid at the time. 265,000 were potentially, you could apply personal responsibility elements to it. Now, is that only X percentage of the Medicaid population? Yes, but it's still a sizable number of people. Greg?
I would just, I think it's multifactorial would be my educated guess, because you're looking at not only responsibility, but we know that in professional liability, the relationship that the physician has with the patient is huge.
Yes.
And so there are a couple of dynamics here. One is that if it's an emergency case and there's no relationship,
Yeah.
there's that. The other is due to fiscal pressures. If you're not allowed to spend more than 5 minutes with a patient, how much of a relationship can you have? How well can you really educate them about their condition and explain to them the alternatives and the risks that are associated with it?
And develop trust.
And
They develop
it's
trust.
about developing trust. There's no question about that. And then, quite frankly, finally, there are situations where people are simply just financially in a terrible place, and they're struggling to make ends meet. They're not unhappy with their physician. They're not unhappy with their care, but they are absolutely desperate. And so they'll file a lawsuit because they feel like they have nowhere else to turn.
I'm going to add one more.
Well, they didn't have access to really good follow-up care like some other patients did. And I know some of our post-op patients went into homes that were very, very dirty. And I've got calls from nurses and everywhere else.
And that was the other component I didn't mention is it's typically a much higher risk population.
And
Yes, ma'am.
I'll add, they also aren't on Medicaid very long. So, we're talking about trying to change someone's life long-term. They may be coming off and on month to month. So you as a doctor, they may have had Medicaid this month. You saw them. They need their follow-up care. It's 2 months later. Well, they've lost their Medicaid. So it's not like other people, when you buy health insurance, it's usually a year. Medicaid doesn't function that way. So it creates a
Should it?
continuity process. I think there's real questions of moving Medicaid more. I mean, this gets into what's conservative and not, but moving Medicaid into more of a mentality of teaching people health insurance, right? So you're stair-stepping in, you're trying to lift people out of poverty. We should have a goal of helping them come out of Medicaid. But as soon
Yes.
as they come out of Medicaid, there is actually no health insurance option for them, right? There is a block there. Also, you're going from 100% being paid and it being month to month and all these things to then suddenly you wanting them to buy health insurance and have the responsibility of monthly premium and it be an annual process and have annual enrollment. None of it's consistent and matches. It's not sort of a consistent, cohesive system where you're teaching someone the value of being responsible for purchasing health insurance or doing direct primary care or doing those pieces, if that makes sense.
Or better yet, maybe a root cause analysis of why they're on Medicaid in the first place.
Right, and that gets another thing is all we do in Medicaid is pay for health care. Would it be beneficial for us to start thinking about having dollars spent on getting them out of Medicaid so that you're reducing caseloads and reducing the amount of money the state's
That is
spending?
exactly, I won't forget you. That is exactly the great benefit of the work responsibility, PWARA back from 1996. You watch the TANF rolls drop by 60% over 5 years. Now, I will grant you that we've got 2.9 million are children. Well, they're children, okay? They're going to stay on Medicaid until their families are making enough money.
Right, but I have one plan, Community Health Choice in Houston, that's paying scholarships out of, they have a fund
Right.
to help moms who just had a baby
Baby.
go to school and get a job, right? So that their child won't be on
That's
Medicaid for
exactly,
long
by the
term.
way, what they did
Yeah.
in TANF and SNAP. Yes, young lady.
Yes, I know there is only 1 minute left, but just as a background, my husband represents both provider sponsorship, HMOs, and ERISA Plus in a variety of capacities, and he concentrates his practice on regulatory matters in addition to complex healthcare reimbursement issues on behalf of both plans and in providers as a healthcare attorney. But I just want to tell you that both of us, he's 52, I just turned 50, the best thing that we found was private care through concierge medicine, and I congratulate you, doctor, for doing that. This is the best thing that has happened to us. We are both healthy, and I just will encourage more people to do that, the private care, because we are happy with our doctor, and we have a personal relationship with our doctor. So I just want to say that.
Thank you.
Thank you very much. Thank you for our wonderful panel and for you as well. Thank you.